Well, good afternoon out there, guys. Dr. Tony Brown coming to you with another edition of Clinical Pearls and Profits. So we will just take up where we left off. We're going over all of the labs that can be found in the VirtualClinic portal. And the idea is I'll give you some basic guidance on the labs. If you should perhaps have a situation where either you or your practitioner or your clinician or even your patient has something out of the ordinary, some kind of red zebra, if you will, feel free to give us a ring. We can consult by telephone, by email, or even by text. Okay, but we'll go over the basics. We'll go over the basics now. Okay, so I believe we've done glucose. We did blood urea nitrogen. Remember, we covered that as one of the indicators of a healthy kidney or failing kidney. Also, along with BUN, we covered creatinine. We mentioned how the creatinine-BUN ratio would allow you to determine whether or not a problem was pre-renal, renal, or post-renal. Bilirubin. So with bilirubin, the idea here, guys, is that there's a couple of kinds of bilirubin. There's conjugated bilirubin and unconjugated bilirubin. What I want you to think about is the fact that whenever you break open a red blood cell, what happens is bilirubin spills out. It's actually heme, and then the heme gets converted to biliverdin, and then the biliverdin gets converted into unconjugated bilirubin. Unconjugated bilirubin then gets converted into bilirubin. So bilirubin comes in a couple of forms, unconjugated and conjugated. You put those together and we look at something called total bilirubin. Okay. You might also see on your lab reports the words direct bilirubin and indirect bilirubin. Okay, so remember that unconjugated bilirubin is indirect bilirubin. Conjugated bilirubin is direct bilirubin. The idea when we talk about conjugation is, remember that the job of the liver is to take substances which are fat soluble, drugs, bilirubin, and change it into something that is water soluble so that the body can excrete it out. Okay, so and then the things that are responsible in the body for conjugating bilirubin, okay, bacteria. We've got various bacteria and enzymes that are freestanding enzymes that are going to be involved in that. All of that is to say that when you look at bilirubin, I encourage you to consider it a major marker of two things. One, liver. Okay, and I say liver because if you're trying to diagnose a GI problem, you need to know if the problem's coming from the liver, if the problem's coming from the gallbladder, or if the problem is farther down past the common bile duct. Okay, bilirubin numbers can give you a sense of what's going on there, just like the creatinine-BUN ratio can give you a sense of where the problem is with the kidney. So not only liver, but as I said, red blood cells. Bilirubin gives you an idea of how much red blood cells are being broken down inside the plasma. Conditions that might cause that, malaria, right? That's what the malaria is all about, is you have a pathogen attacking your red blood cells. Sickle cell anemia. So this can tell you the difference in whether or not your patient might be in the middle of sickle cell crisis or not, because those cells get broken down in the spleen by endothelial macrophages, and their bilirubin spills into the blood system. Sometimes when a person takes penicillin, okay, the body doesn't react to the drug, nor does the body react to red blood cells. But sometimes when the penicillin drug accidentally attaches to a red blood cell, the unit that is created is considered foreign by the body. And the body will then send out antibodies to attack it. And what you end up with is broken red blood cells and increased bilirubin levels. Okay. There's also a condition called paroxysmal nocturnal hemoglobinuria, which is this is a condition that typically happens at night. Whenever we go to sleep, the acid level in our blood increases, and it causes the body to want to attack red blood cells. So when you wake up in the morning, what you have is a little bit of blood in the urine. Runners sometimes get hematuria, right? Red blood cells broken open and passing into the urine after a long, hard 26.2-mile marathon. So I'm just giving you ideas of when you see increased bilirubin, some of the differential diagnoses that you might want to think about. Let's take a look at uric acid. So with uric acid, remember that this is a end product of the breakdown of purine. Where do we find purines? We find them in meat, right? So that is to say, when you have a patient who eats a lot of red meat, you'll find them breaking down a lot of purines. Therefore, the purines, which are converted into uric acid, it builds up in the joints. And once it builds up in the joints, that's when you have the pain being caused. Okay. Now, that said, there are substances that will compete for uric acid. Alcohol, for instance. You have a patient that drinks alcohol and they happen to eat some red meat. What the body does is it puts the poison in line in front of the purine while it's busy metabolizing the alcohol. The uric acid is busy building up, and bad things begin to happen with the gout. Okay, high protein diets can also cause it for obvious reasons, since this is just a byproduct of broken down protein. Iron, can't get away from iron, right? That's probably, with regard to iron deficiency anemia, that will likely be one of the most common types of anemia that you're going to see. Excuse me. Remember that with regard to the iron, your normal range is 35 to 150 micrograms per deciliter, things. I mean, we think about it as, melees and being tired and no energy, but you needed to form proteins. You also, of course, needed to make hemoglobin, which is how you transport oxygen from the lungs to the tissue. You needed myoglobin, which is how you transport oxygen in your muscles. Cytochrome, right? This is a protein that is inside of the mitochondria. And so if you want your mitochondria, the powerhouse of the cell, to work correctly, then you need the appropriate iron. Drinking alcohol, just touching back on that from the last slide, the mitochondria is one of those things that the alcohol takes out. It does something called uncoupling of oxidative phosphorylation, which is a fancy way of saying breaking your mitochondria so that they no longer create energy. Things happen, right? Because that is the powerhouse of the cell. You also need iron to take care of not only cellular respiration, but peroxide deactivation. Peroxide, right? Your body makes its own hydrogen peroxide to fight bacteria. It also makes its own bleach to fight bacteria. And but you don't want that stuff floating around willy-nilly. When you're done using it, you need to break it back down. And so you are going to be in a situation you are iron deficient, where if you're iron deficient, where you won't be able to break down peroxide, and it's made as a good thing, right? It's made as a good thing. However, if you have too much of it, then what's going to happen is, well, let's talk about the good thing. It's a good thing because it's supposed to help fight free radicals. Okay, but having too much of any good thing is not good, because what your body starts to do then is to shut down on how much free radical ammunition it makes, right? It sees that it has enough and says, hey, I don't need to make any more. And Murphy's Law would say just about that time you'd get a bacterial infection and bad things happen. When do you see iron deficiencies? Um, One of them is going to be with liver disease, because the liver makes proteins that are responsible for the transporting of iron back and forth, right? So if you are unable to make transferrin, is the name of the protein, transferrin would be unable to go to the bone marrow, grab the iron, and bring it back out as you need it. Um, Women with heavy menstrual flows. Now, this one, I say take that with a grain of salt, because the creation committee figured this out, guys, that some one sex of the species does not have a menstrual flow. That's the one with the Y chromosome, and the other one does, the one with two X chromosomes. So it is not the case that once a month that the sex of the species that has a menstrual flow is going to be iron deficient and suffer all of the pathophysiologies that go with that. No. Will the iron levels drop? Yes. Should they drop out of normal range? No, they shouldn't. What does that mean to you? That means when your patient comes in and she happens to be in the middle of her menstrual flow and she presents with low iron studies, do not be the one that lets her walk out of the door with an explanation of, oh, it's because you're in the middle of your menstruation, right? Because if menstruating takes her out of the normal range, I don't mean trending normal, out of the normal range. If that takes her out of the normal range, it's because she was already trending low for some other reason before her cycle started. That's what you want to chase, right? Why was she even so low before the cycle began? And then, of course, we not only have low levels of iron, we have high levels of iron. Okay, so you can have hemochromatosis, and you'll remember that. It's just a buildup of a lot of iron in your blood, in red blood cells. Easiest way to solve that is phlebotomy. Patient comes in every so now and then and has their blood drawn. Liver damage, right? We mentioned how liver damage can cause low iron levels. Liver damage can also cause high iron levels, because the liver, the maker of all proteins, is also responsible for making the proteins which are tasked with getting iron out of the blood and taking it to the bone marrow. Right? So let's be clear, there's no confusion here. Transferrin, okay, is what we talked about earlier. And what I'm talking about now is a protein called hemosiderin. Hemosiderin. Hemosiderin takes the iron out of the plasma, excuse me, and delivers it to the bone marrow. What happens if my liver is not making hemosiderin? Then all that iron that's sitting in the plasma waiting to be taken to the bone marrow just stays in the plasma, building up, and then you get hemochromatosis. And then the last one here, well, there's also pernicious anemia, right? An inability to um, absorb your B12, inability to absorb your B12, and there is hemolytic anemia. It's the last one on the list. So with hemolytic anemia, remember that it's just a fancy word for breaking open of red blood cells. And we already went over lots of reasons that those blood cells might be broken open. So now let's talk about alkaline phosphatase. The alkaline phosphatase, the majority of it, it ends in ASE. What does that tell you? It's an enzyme. The majority of this enzyme is going to be from activity in the liver or the bone. Activity in the liver or the bone. Bound primarily to cellular membranes. The idea here is that when would you have increased phosphatase? You can have increased phosphatase activity when you have increased bone building. Okay, when might I see that? Well, women of a certain age at some point start to have pathology in their bone, right? Go from osteomalacia to osteoporosis. And the mechanism of that is not as simple as you think it is. So let me just give it to you so that you know if you are suspecting that a woman is going into perimenopause, or if some of the reasons for a fracture in her hip or easy fracture or repeated fractures of long bones in the body, if you're suspecting something like age-related osteoporosis, you not only should be looking at alkaline phosphatase, which is, as we said, an increase in that bone production activity, but you should also be looking for there's two cells, osteoblasts and osteoclasts. Osteoblasts build bones, the three B's. Blasts build bones, and then the other one's the other. That means that osteoclasts are responsible for destroying bones. Now, of that said, the role that estrogen, which is what a woman of a certain age starts to lack, in a 20-year-old woman, estrogen has two jobs. We usually only talk about one of them, but it really has two jobs with regard to bone growth. Job number one is it activates osteoblasts to build bones. Believe it or not, that's the minor job. The major job of estrogen is to inhibit osteoclasts from destroying bone. So what we're really saying is that when your patient gets to a certain age and starts to become estrogen deficient, sure, she is activating fewer osteoblasts to build bones. But the real moral of the story is that there are so many more osteoclasts that have been disinhibited from destroying bone, and they just start breaking down that bone willy-nilly. Okay, so as a matter of fact, estrogen has a second name which nobody uses. It's called osteoclast inhibiting factor. Okay, so those are some of the things that you want to look through when you're thinking about doing your differential diagnoses when you see increased levels of phosphatase. Placenta implies that pregnancy. It's also related to pregnancy, but as we said earlier, 80% of the reasons, let's say this in a different way. With an increased phosphatase, if you think about liver and bone, 80% of the time you'll be right. So no need to, unless you deal with a lot of pregnant patients, really no need to master that one. All right. So why would one have alkaline phosphatase decreased, right? Excuse me. It could be related to malnutrition, protein deficiency, and vitamin and mineral deficiencies. Okay, a lot of things there. There's lots of differential diagnoses for decreased. And I would say that increased phosphatase is going to be a lot more specific and sensitive. Well, sensitive. Yeah, increased phosphatase is going to have a higher sensitivity than decreased phosphatase. In other words, if you see increased phosphatase, there's a pretty short list of what your differential diagnoses are going to be. We just talked about a few of them. If you see decreased phosphatase, it's a long list. I would not use decreased phosphatase as a springboard to generate my differential diagnosis list, right? Look for some other lab, and that should be able to help you. So realize that oral contraceptives are going to also decrease your ALP, your alkaline phosphatase levels. Make sure you mention with your patient who walks through that door, right? They don't want to be with a woman who's taking oral contraceptives and smoking. Why? Because estrogen, which has been classified by the World Health Organization as a carcinogen, by itself is a carcinogen. Smoking is carcinogenic. You put them both together, where the smoking causes neutrophils to come over and damage the endothelium of the blood vessels, and you put that along with the increased estrogen, it's just a setup for a blood clot. All right, so smoking by itself is a carcinogen. Estrogen is a carcinogen. Estrogen by itself also is prothrombotic, causing thrombi. And then you throw all of that together, blood clot will come. They are predisposed for something called, what is it? Budd-Chiari, right? Budd-Chiari, which is a clot just distal to the liver in the hepatic vein. And then fibric acid derivatives will also decrease it. And we've already talked about pernicious anemia. Okay, let's make it to the next slide here. So we mentioned earlier when we were talking about bilirubin, how it can give you some idea of where a blockage might be. So between the liver, gallbladder, right, common bile duct. Turns out that alkaline phosphatase can also help you to narrow that down. So obstruction of the biliary tract is going to be something that causes increased alkaline phosphatase levels. What can obstruct those tracts? Gallstones or an infection. Okay, if your liver enzyme is elevated too, let's say this differently. If your alkaline phosphatase is elevated and your GGT from your liver is elevated, then most likely the trouble is going to be from the biliary tract. This is really kind of wonderful combination to memorize, guys. And there's 3 combinations to memorize between alkaline phosphatase and liver enzymes, and they save you a lot of time. If you've got obstructive gallstones, right, and your alkaline phosphatase levels are twice the normal, then what you might see is that your bilirubin, we're going back to that, is going to rise at a similar rate. Okay, let's say that differently. If you're thinking that the diagnosis is obstructive gallstones, okay, look for bilirubin moving in the same direction and rate as your alkaline phosphatase. If that's happening, then you're thinking gallstones. How cool is that, right? It's not only easy, it's just like super cool. And we mentioned earlier that there are other types of alkaline phosphatase. If the intestinal alkaline phosphatase is elevated, then you would be thinking cirrhosis, right, of the liver, intestinal infarct, inflammations and ulcerations. So You know, that's going to be that businessman in the mid 50s to mid 60s who's been traveling a lot, eating a lot of bad food, drinking a lot of good alcohol. That's who you're going to be thinking about there. And you're also going to see increased levels as a tumor marker. This is a big one, but you know, I don't know how many people you're going to get in that fit that category, but this is a really, really nice sensitivity marker for catching tumors. Bone injury, as we've already said, because after your bones get injured, you're going to make more, and therefore you increase your alkaline phosphatase. Pregnancy, we've already mentioned. Paget's disease, right? Because with Paget's, that's one of those diseases where you have this malformation of the bone, and it's going to show up in phosphatase levels. Osteosarcoma in that kid, um, not only in kids, but most commonly. Tumor metastatic to the bone, and metabolic bone disease. The point is bone disease, bone disease, bone disease, bone disease. And then the last two for the day, remember that children, because they're growing, typically have levels as high as 4 times of alkaline phosphatase compared to adults during that first decade of life. So yeah, when you're looking for an osteosarcoma, you do want to take that into account. Anti-epileptic agents and smoking all cause elevations, right? So benzodiazepines is an example. Um, if your patient comes in, you do the labs, you do notice that the alkaline phosphatase levels are raised. One of the questions you want to ask yourself before you keep digging around is this patient on an anti-epileptic medication? Okay, guys, you did it again. Wasted a half hour of your life with me just nerding out. So I do appreciate it. Next week we will take up with the next slide that comes after this one. That's going to be protein. Okay, we'll start out with protein next week. Okay, have a wonderful week out there, guys, and we'll see you next Tuesday. Bye-bye.